Good morning. Welcome to the BIOTRONIK Satellite Symposium at the ESC 2021, which is dedicated to the future direction of remote cardiac monitoring. Today we have two excellent speakers, and I like to introduce the first presentation, which will be given by Professor Niraj Varma, and the title is Alert-Driven ICD Follow-up, a model of digitally driven remote patient monitoring. Please, Niraj.
Thank you very much. It's my pleasure to speak on this improved method of remote patient monitoring, which produces advantages for clinics and for patients. These are my disclosures. So we know that after an implant of an ICD or a CRT, the recommended follow-up of those patients is every 3 months evaluation. And conventionally that's been done in person. This presents a problem to clinics because of the large volume of patients that we have to manage. So regularly seeing these patients in appointment-based care is challenging in terms of load for a clinic. Remote patient monitoring for over 20 years has been advocated to produce benefits in terms of reducing in-clinic evaluations of the patients. But still, 3 monthly evaluations have to be conducted. What is the value of 3 monthly evaluations? Well, the actionability, that is the need for device reprogramming, device troubleshooting, or addition of medical therapy, is less than 10%. Less than 10%. And what this means is that a large number of the patients who turn up for regular appointments have non-actionable visits and may be considered to be unnecessary load on overstressed device clinics. And true, with remote follow-up at 3 monthly intervals, the patients don't actually have to present to the clinic, but nevertheless there's a lot of work required in coordinating these patients with the clinic for these transmissions. However, home monitoring presents a quantum leap forwards in remote monitoring technology. This is an automatic remote monitoring technology that provides continuous monitoring. So the device provides data every day of device diagnostics regarding device condition and also disease condition. This is relayed telephonically for centralized processing, and only those data that are necessary are presented to the clinic. So this form of remote monitoring provides significant potential. It provides a potential for alert-based care. And what I mean by that is the patients who need to be seen here are automatically flagged by the system and they can be brought to the clinic. And those patients who don't need to be seen on a routine basis and are essentially well do not need to be brought into the clinic. So alert-based or exception-based care. So this was tested in the TRUST trial, and this paper is online just now. And I will be presenting the results of this study in the following slides. So the TRUST trial protocol was presented several years ago, and this addressed conventional care every 3 monthly post-implant clinical appointments in the hospital versus remote monitoring. So after the 3-month compulsory visit, no in-clinic evaluation was scheduled for 1 year. But remote monitoring, home monitoring, was activated. So this was a period of exclusive remote patient management, and we practiced alert-based care. And the primary endpoints of the TRUST trial were to evaluate patient safety, non-actionable healthcare utilization, and the hypothesis was that this would be reduced with the use of alert-based care, and yet preserve early detection of at-risk patients. So these are the results. First of all, safety. Major adverse cardiovascular events were no different between conventional care and home monitoring. So a period of exclusive remote monitoring did not cause any patient harm. This was very important. Another interesting result was that patient retention was improved 20% at 1 year by home monitoring compared to conventional care. That means that despite the lack of in-person evaluations, exclusive remote monitoring better maintained follow-up of this community of patients, all of them together, including the at-risk patients versus non-actionable patients. This is the primary endpoint, and we see that with remote monitoring using home monitoring, freedom from non-actionable in-person evaluations, that is, the number of patients who did not need to be seen, who were actually not called to the clinic and did not have to attend the clinic, was significantly improved. So that almost 62% of patients in the trial, there's almost 1,000 patients here, did not have to come to the clinic unless it was necessary. In comparison, in conventional care, there was a significant attrition here, and many patients attended for what are essentially non-actionable visits. So this difference yielded a almost 80% reduction in unnecessary clinic visits. So the figures in blue here did not have to come to the clinic unless they became red figures, that is, at-risk patients. So how did we do with those? Well, one of the important things is that home monitoring assures connectivity. There is no patient or clinic interaction. And transmission success per patient was 91%. 91% of daily transmissions were successfully received. This might seem intimidating, but remember there's centralized analytics here, and therefore only a fraction of those were actually presented for physician review. In fact, only one alert transmission was triggered per patient during the year on average, resulting in more than 50% of patients not triggering any event notification over 1 year. But when they did trigger an event notification and they were called into the hospital, the actionability was more than 50%. So this is a tenfold increase in the actionability rate of an in-person evaluation compared to a scheduled 3-monthly check. So a vast improvement in the way that we manage patients. What does this mean? Well, the number of in-person evaluations that were conducted in order to discover one actionable event was reduced from over 8 in conventional care down to 2 for event notification. So that's from the clinic point of view. From the patient's point of view, we would like to detect the at-risk patients. So in conventional care, it took more than 30 days median, and perhaps extending out to half a year in some instances, for detection of at-risk patients. In home monitoring, it was approximately 48 hours, including silent asymptomatic events. What does this mean? Well, for device related issues, we could discover these events early, before the patient even did, and before patient morbidity occurred. And here is the promise for disease management. Here is an in-clinic interrogation, conventional care for a patient presenting with heart failure. And we see that events started 3 months beforehand with atrial fibrillation, rapid ventricular rates, loss of CRT pacing, reduction in patient activity, change in thoracic impedance. Perhaps in this patient, if we had been notified earlier by alerts, and with Dr. D'Onofrio will explore this in greater detail, we might have preempted this congestive heart failure admission. So a significant promise there for disease modification. Patient benefits. Again, at-risk patients need to be seen early, and alert-based care promises earlier identification, as I have shown, and also improved care. So alert-based care, despite the lack of scheduled checks, in-person evaluations were 57% greater amongst patients developing adverse events, the red figures, so they were correctly identified. Remote patient monitoring intensified evaluation of those at risk and earlier. From the device point of view, within 1 year there was a 10% improvement in battery capacity because of improved device management. And of course, remote patient management offers significant advantages to patients. The old way is very cumbersome, very awkward. Patients live significantly at significant distances from the hospital. It takes a long time to come to the hospital. There's interruption of the workday for them or for an accompanying person. Alert-based care removes many, if not all, of these encumbrances. So we were forced by the pandemic to adapt our regular practice to essentially exception-based care, and this was endorsed by the arrhythmia professional societies around the world. The proposed care pathway is continuous monitoring, patient status visible in a dashboard-like interface, which is what the home monitoring system provides. Only alert level conditions are directed to clinicians for review and ultimately to the medical record. This largely eliminates non-actionable transmissions, eases clinic burden whilst pivoting focus to actionable items. And this system is what I've just shown you from the primary results of the TRUST trial, and also been advanced by a perspective statement here which suggests that this is the way to go to the future. So I think this will be a significant improvement compared to conventional care here, which is laborious and most of the work is essentially non-actionable. We provide a simpler method for follow-up, reduced in-clinic evaluations unless necessary, and closer follow-up and monitoring of patient conditions. Thank you very much.
Thank you very much, Professor Varma, for the excellent presentation. You showed a really innovative approach for the ICD-4 based on alert-driven philosophy. Could you tell us, please, how do you see the impacting this the remote cardiac monitoring in a clinic? So, what is from the clinical point of view the most important issue?
Yes, so I think from the clinic's point of view, managing remote monitoring generally, and in our clinic we use all the systems. Some of them, particularly the earlier remote follow-up device that I showed the cartoon of earlier, requires a lot of clinic work to coordinate with the patient. So sometimes this generates more work than necessary. Automatic continuous remote monitoring reduces that load for the clinic in coordinating with patients. At the same time, the centralized processing filters the remote data so that clinicians are only directed to the patients they need to see. So this is a much more efficient way of conducting clinical care in a remote follow-up clinic.
Thank you very much. And how do you see the alert-based monitoring in the COVID-19 pandemic? So we are now, hopefully, at the end of the last phase, but what was the experience during the COVID pandemic?
Yeah, so COVID-19 is obviously a tragedy for the whole world, and it forced us to adapt our practice so that there was restricted access to hospitals and restricted personnel in hospitals, restricted staff in hospitals, and who were all overstressed. And yet we had to maintain routine care of our patients, including patients with implantable devices. So we had to adapt to the environment, and therefore we really switched to alert-based care. We eliminated routine 3-monthly checks, and we monitored patients on alert-based monitoring data. And we found this to be very effective. So that experience, I think, has made us think of different practice patterns. And this was tested in the TRUST trial and published concurrently during the pandemic and showed that this system actually is very effective. And I would emphasize that one needs continuous monitoring, centralized analysis so we're not overloaded with unnecessary data. And the connectivity has to be assured. So it has to be a robust transmission platform. We tested that in TRUST and it was shown to be so.
Thank you very much. So, and how do you see the patients? They will have the major advantage of this type of follow-up.
So patients have also found this very acceptable. They relished the fact that they did not have to come to the hospital for a routine device check every 3 months, only to be told the device was fine, everything was fine. It's a significant waste of patients' time. At the same time, patients do have other conditions, and they need to be seen for those, whether it's coronary disease or heart failure. And those visits are much more productive than routine device evaluations. Patients also were reassured that they were continuously monitored despite not having to come to the hospital. In fact, continuous monitoring offers the advantage of detecting problems in between those 3 months that they would otherwise be coming to the clinic at. So they have been reassured by the fact that we have closer communication, closer linkage with the patient, and we can identify at-risk conditions even if they don't feel them, and therefore we can enable preemptive therapies. And that goes for device function as well as disease intervention.
Thank you very much, Professor Varma. Once more, it was excellent. And now, ladies and gentlemen, I'd like to invite the second speaker, Dr. Antonio Donofrio, who will tell us about the combined home monitoring trends predict heart failure hospitalization. Please, Dr. Donofrio.
Mr. Chairman, dear colleagues, good morning. After the excellent presentation by my friend Niraj, it is a real pleasure for me to speak about how to combine home monitoring trends to predict heart failure hospitalization and show the results of our SELENE heart failure study. I have no conflict of interest. Acute heart failure is a serious epidemiological concern. It is associated with the poor prognosis and high rehospitalization rates. Despite medical therapy has improved remarkably in recent years, it cannot halt disease progression. Therefore, each new hospitalization makes subsequent episodes more likely. Therefore, prevention is the key word here. The selection of potential predictors of worsening SELENE heart failure study was a prospective, multicenter, non-interventional, event-driven study with the post-hoc randomization to derivation and validation subgroups. The objective was to develop a predictor for worsening heart failure hospitalization based on trends of home monitoring parameters. The primary endpoint was the first post-implant hospitalization for worsening heart failure. Secondary endpoints were any hospitalization or death or outpatients intravenous interventions for worsening heart failure. Investigators were blinded to home monitoring trends in order to ensure that whatever medical reaction would have been taken, it was not triggered by free interpretation of home monitoring trends. All study endpoints were adjudicated by an independent clinical event committee based on medical records and the preset charter. We included patients with recommended indication to CRTD or ICD device provided with atrial sensing, that is dual chamber ODX devices, reduced the ejection fraction, and NIA class 2 or 3. We excluded the patients presenting with the permanent atrial fibrillation, previous stroke, acute decompensation in NIA class 4. We enrolled 918 patients remotely controlled with the home monitoring system with a median follow-up of 22 months. 60 heart failure hospitalizations were adjudicated as primary endpoint events. Before analysis, the entire cohort was randomly allocated to a derivation in the validation group with a randomization procedure stratified by the number of primary endpoint events and device type. This allowed separate analysis to derive the predicting index and to test it in an independent subgroup. Patients' characteristics are shown in this slide. That data are consistent with a cohort with mild to moderately severe heart failure. About 50% of patients were in NIA class 2 at time of implant. Almost half of them received a CRTD device. 45% were ischemic cardiomyopathy. No significant difference in main baseline parameters were observed between study cohorts. The predicting algorithm was derived from temporal home monitoring trends of 7 diagnostic parameters, each of which is shown to be associated with the worsening heart failure or death. Each of these trends was screened for specific patterns and time frames associated with an increased risk for heart failure. The patterns were evaluated using a predefined set of numerical transformation like slope, stability, or irregularity. Time frames were individually optimized for each home monitoring trend and ranged from 7 to 90 days prior to hospitalization. The results of the numerical transformation of each trend were weighted and summed up to calculate a single index score. Consecutive daily index score were then used to obtain an index trend over time. During the longitudinal analysis, the index was calculated daily with each available home monitoring transmission. After 3 days, with the index above the nominal threshold, an alert is raised. The index switches to an alert status in which a recovery threshold is used. As soon as the index goes below the recovery threshold, the alert status is reset and the patient is no longer classified at risk. Of course, the sensitivity is the percentage of alerted endpoint events that is occurring during a recovery threshold interval. The false alert rate is the rate of alerts not followed by a study endpoint event. Unexplained alert rate is the rate of alerts that were totally unexplained, that is, that were not followed by any reported adverse events. These are the results of the validation analysis. We generated the modified receiver operating characteristics curves, plotting sensitivity versus false or unexplained alert rate by varying the nominal threshold. We did it in both the derivation and the validation groups. The curves were similar. More in detail, the slides show the sensitivity performance in the predefined range of nominal threshold, 3.5 and 4.5. The sensitivity ranged from 66 to 72%. At nominal threshold 4.5, we observed 66% sensitivity for primary endpoints and 55% for secondary endpoints. Alerts were raised 42 days before the event as median value. Analysis of specificity showed a rate of unexplained alerts that was always below 1 per patient per year, with the nominal threshold between 3.5 and 4.5. At nominal 4.5, specificity was 85%, and the false and unexplained alert rates were 0.69 and 0.63 per patients per year, respectively. This is about 1 inappropriate alert 17-18 months in individual patients, which is remarkable is compared with other predictors. In conclusion, dear Chairman, dear colleagues, temporal trends of several home monitoring variables can be used to efficiently predict the worsening heart failure hospitalization. Time scale of changes in temporal trends differs among variables 7 up to 90 days before acute heart failure. We combined 7 variables in one single index adjusting with a baseline clinical stratifier, the Seattle Heart Failure Model Score. Developed index is characterized by remarkably low false alert rate, 1 in 17 months, and competitive sensitivity, 2 out of 3 episodes. Alerting time allows careful evaluation of appropriate reactions. Obviously, controlled studies are needed to define proper use of the index in routine practice workflow and estimated associated clinical benefit. Thank you for your attention.
Thank you very much, Dr. Donofrio. It was an excellent presentation, and now we have time for a few questions, if I may start. The first one will be that what are the main benefits that such study results can bring to the patients and to the clinicians?
Thank you for your question. Well, for patients, keeping them out of the hospital, that would be the major achievement. If the tool we have developed will prove effective also in routine practice, we would have appropriate alerts for the majority of impending acute heart failure events, sufficient time for additional evaluation and assessment to take the right decision for the right reaction, sufficient time to avoid the further exacerbation, eventually leading to hospital admissions. We would also have a very few false alerts, which is the major benefit for clinicians and for the healthcare system in general, as false alerts are the main source of inefficient resource consumptions, as we all know. So, reduced hospitalization, limited number of false alerts and unnecessary reactions, everything seems to me to go in the direction of reduced clinical burden in the management of heart failure patients.
Thank you very much. And the results of the SELENE HF study show that the algorithm can predict heart failure hospitalization or rehospitalizations in advance by combining multiple parameters into a single composite score. How do you see this applied to your clinical practice, and how do you think it could impact the clinical workflow for the management of heart failure patients?
Well, since years, we have been looking at several variables on the home monitoring service center that we know are somehow related to heart failure. But so far, we were not able to interpret them and quantify the risk in association to their change. Now, we have a tool that allows simplified risk evaluation. Nurses and technicians will be more empowered to make correct evaluation now, contact the patients early, and follow up before symptoms worsen.
Thank you, Antonio. These are very exciting results. One of the challenges that we've had in remote monitoring of implantable devices is sharing the right data with the right teams. So how do you think the results of the SELENE HF study can improve collaboration between the device team and the clinical heart failure team? What is needed to make it work?
Heart failure is a systemic disease involving multiple organs. A multidisciplinary approach is absolutely needed. The composite score that we have developed favors a more rational and comprehensive patient management, pooling skill and expertise from both EP and heart failure specialists as one teamwork. For example, both EP and heart failure teams may assess the home monitoring service center and organize their workflow according to preferred settings. I think there is no one standard model, and the workflow should be optimized in different way, in different model, in different clinic, region, and country. However, a synergic approach between EP and heart failure specialists is needed, and the home monitoring service center implementing a heart failure predictors as one that we have developed may represent a platform where multidisciplinary management can meet.
Thank you.
Thank you, Niraj.
Ladies and gentlemen, let me conclude in a few words. I strongly believe that the remote monitoring should be today a real standard in each modern arrhythmology center. Because remote monitoring enables to increase your patient's comfort and satisfaction while saving your time and overall effectiveness of the follow-up. Professor Varma nicely showed that the implementation of alert-based care has proven to reduce unnecessary visit and also improve the clinical efficiency. And the presentation given by Dr. D'Onofrio nicely showed that the transcending management of heart failure patients from detection to prediction is the key to the reduction of HF hospitalization. Thank you very much for the attention. I have to thank you for both presentations. It was an exciting time, and thanks once more.
Thank you very much.
Bye.
Thank you.